Let's jump right into this high-yield explainer on neoplasia. We designed this specifically as a rapid board review to really solidify the terminology and those crucial diagnostic steps you're absolutely going to need for your exams. If you're a medical student prepping for the boards right now, you are exactly in the right place.
Here's our study agenda for today. We've got 5 sections: defining abnormal cell growth, benign versus malignant tumors, carcinoma versus sarcoma, cancer grading and staging, and finally, diagnosing and tracking neoplasia. We're structuring this by tracing the pathological progression, so let's get right to it.
Section 1. Defining abnormal cell growth at the cellular level. Let's start with the highly tested foundational terminology, specifically looking at how normal cells begin to go rogue.
First up, we have dysplasia. Now, the classic board presentation here is that despite the obvious cellular disorganization, like pleomorphism, where cells wildly vary in size and shape, and hyperchromasia, where their nuclei stain super dark because of all that increased DNA, it is completely non-neoplastic. So the absolute crucial point to remember for your exams is that it's reversible. If the chronic irritation or inciting stimulus stops, the cells can go back to normal. Think of it as a serious cellular warning sign, but one that can still be walked back.
As we step things up to carcinoma in situ, or CIN, the ultimate differentiator becomes crystal clear. The basement membrane is perfectly intact. Even though these cells look completely malignant under a microscope, with severe anaplasia and mitotic figures everywhere, zero invasion has occurred into the underlying stroma. It's a true neoplasm, for sure, but it hasn't crossed that critical structural boundary yet.
And finally, we cross the line into neoplasia, which literally translates to new growth. This is the point where the growth becomes completely independent and uncontrolled. It persists long after the initial trigger is gone. And you know, that persistence is key. The cells have completely escaped normal regulatory control. It's just an uncoordinated, excessive proliferation that simply no longer listens to the body.
Section 2. Benign versus malignant tumors, tissue-level characteristics. Moving up from the single cellular level, we need to clearly distinguish between benign and malignant tissue masses.
You'll absolutely want to lock in these differences. While benign tumors are typically well-differentiated and stay completely localized, malignant tumors can range all the way from well-differentiated to entirely undifferentiated, which we call anaplastic. Crucially, malignant tumors are never encapsulated, and they exclusively possess the ability to metastasize to distant organs. Actually, let me repeat that for emphasis. If a test question mentions metastasis, you are definitively dealing with a malignancy. There are absolutely no exceptions to that rule.
Section 3. Carcinoma versus sarcoma, naming the threat. To further break down malignant tumors, we rely on nomenclature that's based strictly on the cell of origin. Here is a classic exam trap you really must know. Carcinomas arise from epithelial tissue, think your skin or the mucosal linings of your internal organs. Because epithelial tissues are intimately associated with lymphatic networks, carcinomas prefer to spread early via the lymphatics. Sarcomas, on the other hand, arise from mesenchymal tissue, things like bone, muscle, and fat. Now, these are less common, but because these tissues are deeply embedded and highly vascularized, sarcomas tend to spread directly through the bloodstream, specifically via the veins. Lock this mechanism and distinction in. It's a real game changer for fundamental pathology questions.
Section 4. Cancer grading and staging. Clinical evaluation. Let's move from identifying the tumor under the microscope to evaluating its severity and spread in the clinic.
But before we look at the specific criteria, I want to test your active recall for a second. How exactly do we distinguish between the grade and the stage of a cancer? It's a super common point of confusion for students. Take a quick mental second to formulate your answer.
Okay, let's see if you hit the nail on the head. So, the crucial point is that grading requires a pathologist looking through a microscope to assess cellular differentiation. They're basically measuring how anaplastic or mutated the cells are, usually on a scale from grade 1 to IV. Staging, however, is a clinical, surgical, and radiographic assessment of how far the tumor has physically traveled in the patient's body.
We evaluate clinical staging using the universal TNM system, which follows 3 logical steps. Step 1 is T, sizing the primary tumor, typically scored from T1 to T4. Step 2 is N, checking for advancing regional lymph node involvement from N0 to N3. And step 3 is M, scanning for distant metastases, scored as M0 for absence and M1 for presence. And remember, between grade and stage, staging is practically always the most important prognostic indicator for a patient's survival. That is a massive, high-yield takeaway you've got to remember.
Section 5.
diagnosing and tracking neoplasia, clinical tools. Finally, let's review the precise clinical tools used to diagnose and continuously monitor these neoplasms in our patients.
We have a pretty layered toolkit available here. Screening methods like mammography catch abnormalities early, and cytological exams like brushing cells or doing a fine needle aspiration give us a really great preliminary look. But your major board takeaway here is that histological examination via an excisional or incisional biopsy is always the definitive method for establishing a diagnosis. You simply cannot definitively diagnose cancer without analyzing the actual intact tissue architecture. It's just absolutely crucial.
And for serological tracking, let's do a rapid-fire flashcard drill on the classic tumor markers. CEA is heavily associated with gastrointestinal tract cancers, especially colon cancer. AFP is a marker for hepatotomas and yolk sac tumors. HCG is classically linked to choriocarcinoma, and PSA is used to track prostate carcinoma. Now keep in mind, we generally don't use these to diagnose the cancer itself, but they are incredibly vital for monitoring a patient's response to therapy over time or checking for recurrence.
As we round out our review, it's really vital to remember that a tumor's clinical effects aren't just local. Sometimes tumors produce ectopic hormones, resulting in remote, systemic issues known as paraneoplastic syndromes. For instance, a small cell carcinoma of the lung might inappropriately secrete antidiuretic hormone, causing severe systemic symptoms completely unrelated to the lung tissue itself. It's a fascinating and, frankly, frequently tested concept on the boards.
To wrap up our explainer, I'll leave you with this thought to spark your curiosity. If our tissues are constantly adapting to stress, at what exact molecular moment does a reversible dysplastic cell permanently cross the line into an irreversible neoplasia? Think about the specific genetic mutations, the loss of contact inhibition, and the exact signaling failures that must happen under the hood for that point of no return to be reached. Keep that in the back of your mind as you continue your pathology studies. Thanks for joining me for this review, and I'll catch you in the next explainer.